interest of time as well. I'm going to start us with this presentation, and it's already been introduced. Our topic today is on non-Hodgkin lymphoma. My name is Kibet Keitang. I work in Eldoret. I will cover, this is the outline. Probably it's going to be more of a general presentation, not specific in terms of the disease, the types of non-Hodgkin's lymphoma, but a general non-Hodgkin lymphoma presentation. We'll talk about some general points on introduction on cancer and lymphoma, a few into the non-Hodgkin group of lymphomas or family of lymphomas, and then I'll talk a little bit on the pathogenesis and the clinical presentation, and then diagnostic process. That is where my strength is, and then just basic tenets of management, and then my co-presenter will shed light on the other aspects of non-Hodgkin lymphoma. I will be as general as possible. To start with, cancer generally is a term that is also called malignancy or malignant neoplasm, basically referring to the uncontrolled, unregulated, and disorganized proliferation of cells within the body, leading to the development of an abnormal growths. So you will hear mostly some of these cancers or malignancies being referred to as a new growth in the body that is uncontrolled, unregulated, and disorganized. If you look at this diagram on the right side of the screen, you can see the top part, the blue cells are what I usually refer to as the normal cells of the body. And you can see naturally a cell as a nucleus, which is usually a dot at the center, and a cytoplasm, the bluish discoloration at the periphery, and it's usually surrounded by a basement membrane. Usually, normally, a cell would divide through the process of cell division into two, and then each of those cells divide in. So you tend to get like a multiple of two division, and these cells usually have boundaries. I mean, they usually don't crowd. They're usually very organized and very regular. If you look at the ones on the lower side, the red ones, you can see number one, the first is they're so lumped together. Number two, they're quite disorganized. And then number three, you can see there's loss of regularity. The cells and the boundaries are not that round. The nucleus is quite big and irregular, and they are not of the same sizes compared to the first ones. And if you can see in the last one, there's a loss of boundaries, meaning the cells get into each other. So these are the characteristic features of malignant tumors or cancers in general. As I mentioned, that cancer is a large extended family of diseases, of course, belonging to the non-communicable group of diseases. And this malignant transformation of cells from normal to abnormal cancerous cells affect any part of the body. And the name of the cancer or the malignancy is largely determined by the cell of origin, the cell in which it has undergone a malignant change or a cancerous transformation. So when you talk about lymphoma, this is basically refers to a malignancy or a malignant transformation of a subset of white blood cells called the lymphocytes. And I will show you in the next presentation that the lymphocytes are also different types. So sometimes you can get malignant transformation of these lymphocytes while the lymphocytes are in the circulation, that is in the blood system. And in this case, it will be referred to as a leukemia. While if it is in the lymphoid tissues either primary or secondary lymphoid tissue, it will be referred to as a lymphoma. So the factory that prepares or generates or produces all the blood cells is usually majorly the bone marrow. And this bone marrow usually have stem cells that proliferate into different lineages. You get your red blood cells from this, you get your white blood cells, and then you get your platelets. Each of these has their own individual functions. The white blood cells are also in different types, but our focus today is on the lymphocytes because we are talking about malignant or cancerous transformation of the lymphocytes. And the lymphocytes are in two main types, the B lymphocytes and the T lymphocytes. And of course, you get some transformed B lymphocytes to become plasma cells that can produce antibodies. So these lymphocytes, as I mentioned, you can get them in the circulation, general circulation, or in the lymphoid tissues. The primary lymphoid tissues that we have are your bone marrow and your thymus. I mean, that is where most of the cells after production, they mature in those areas, like your T cells will mature in the thymus, and the B cells in the bone marrow. Thereafter, they will be released into the general circulation and also into the peripheral or secondary lymphoid tissues like your lymph nodes, spleen, lymphoid aggregates within the GIT or gastrointestinal system, or rather sometimes even the solid organs can have can act as peripheral lymphoid tissues. Of course, in a very basic way, the main functions of all these blood cells are red blood cells responsible for oxygenation or carrying oxygen. White blood cells are responsible for immunity and fighting infections and diseases, while platelets are responsible for bleeding and clotting systems. And these are important because when you get malignant transformation of these cells and they grow abnormally and excessively, eventually some of them fill or occupy the bone marrow, leading to decreased production of these components and eventual loss of these functions. And the loss of these main three functions will present as symptoms. So we've mentioned that like this malignant transformation of lymphocytes, I'll give an example of malignant transformation of B cells, which, I mean, if the malignant transformation of the cancerous change occurs in the immature cells, usually will be referred to as a lymphoblastic. But in maturing or mature stages will act as a B-cell lymphoma. And then in circulation, of course, you will get issues of leukemia. And then once this malignant transformation hits the specialized B cells, or the ones that have that are producing antibodies, they call plasma cells, it's referred to as multiple myeloma. So there's that spectrum based on the localization of either the primary, secondary lymphoid areas or the circulation. So lymphoma, it's important to know that it is a highly heterogeneous disease, meaning it is very many types. It is not one disease. So when we said a lymphoma, in treatment cycles, you have not communicated because there are very many. But there are two main types of lymphomas. One in which we are discussing today is non-Hodgkin lymphomas, but you can also have Hodgkin's lymphomas. And the term Hodgkin is eponym, meaning it is named after someone who in the past described this one of these diseases. It was called the person was Thomas Hodgkin, who lived in the 19th century, 1798 to around 1860s, and he is the person who described Hodgkin's disease. And Hodgkin's disease, as opposed to non-Hodgkin lymphoma, is characterized by the presence of a characteristic cell that is usually referred to as a Reed-Sternberg cell or an RS cells, a specific large cell with multiple nuclei and prominent eosinophilic nucleoli. So it usually has a striking appearance, and the identification of it makes a lymphoma Hodgkin's. Non-Hodgkin lymphoma, on the other hand, are tumors whose origin or cell of origin are either B or T cells. So you can have B cell non-Hodgkin lymphoma or a T cell non-Hodgkin lymphoma. Because I also showed you the process of maturation of lymphocytes from, the bone marrow all the way to the secondary lymphoid organs, you can also get an immature non-Hodgkin lymphoma or a mature non-Hodgkin lymphoma. So that is basically how they tend to classify them. And these are a few examples that I've listed. The list is so large, but I just put in some common examples of non-Hodgkin lymphomas just for our understanding. Commonest, the ones that affect B-cell lymphomas and mature B-cell lymphomas are bucket lymphomas, diffuse large B-cell lymphoma, follicular lymphoma, small cell lymphoma, or basically chronic lymphocytic leukemia, SLL, stroke CLL. These are some examples. Some examples of T-cell lymphomas are peripheral T-cell lymphoma or cutaneous T-cell lymphoma, sometimes referred to as a mycosis fungoides, which presents as skin lesions. The grading of this, by virtue of the names, usually tend to signify the grade as well. Like SLL, CLL would be a low-grade lymphoma, for example, and some subset of follicular lymphomas. Intermediate grade would be a subset of follicular lymphomas and also a few types of diffuse large B-cell lymphomas. And then high-grade ones would be your bucket lymphoma, immunoblastic component of diffuse large B-cell lymphoma, and also lymphoblastic lymphomas. So that is those are a few examples of them. They're quite a number. Okay, can't list all of them. Just also important to note that, as I mentioned, it's a large family of diseases and it's so heterogeneous. So malignant lymphomas would fall under this the last column here, where you have non-Hodgkin's, bucket, cutaneous T-cell examples. The other hematologic malignancies are affecting all the other cells that arise in the bone marrow. So one thing probably I didn't mention is that in terms of the etiology or disease causation, there is no specific cause or like etiologic agent that is responsible for the the causation of non-Hodgkin lymphoma, but largely related to genetic abnormalities that lead to either activation of proto-oncogenes and suppression or disruption of the activity of tumor suppressor genes. So they usually related to some genetic or mutational abnormalities. So symptoms, general symptoms of non-Hodgkin lymphoma. How would you identify that someone has a non-Hodgkin's lymphoma? Number one, usually, I will start with the most specific symptoms. Are usually swellings around the lymph node or lymphoid region distribution, or what is referred to as lymphadenopathies. So you'll have enlarged lymph nodes in the neck, that is the cervical or supraclavicular regions, enlarged lymph nodes in the armpits or the axillar, enlarged lymph nodes in the groin or inguinal, or presentations that would point towards enlarged internal lymph nodes or lymphoid distribution, like mediastinal lymph nodes, retroperitoneal, mesenteric lymph nodes, and pelvic lymph nodes. Of course, mediastinal lymph nodes, if they're very large, they will present sometimes even like superior vena cava syndrome or chest fullness or difficulty in breathing. So that is usually the striking feature or symptom in lymphoma. The other one is for some T-cell lymphomas or even some lymphoblastic or immature lymphomas, you tend to present with the mediastinal symptoms or mediastinal masses or adenopathy. You can get extra lymphatic involvement, I mean swellings in the lymphoid regions or tumors arising from the lymphoid aggregates in the gastrointestinal system, of course, stomach or the intestine, and testicular region, bone or ovarian. Commonest sometimes that we see in young populations, you can see like a bucket lymphoma presenting as an ovarian mass, that someone has to be very careful to consider it in a young patient presenting with a rapidly growing pelvic mass or ovarian mass. Also in the gastrointestinal system, we've seen several bucket lymphomas presenting as a intestinal obstruction or a rapidly distending abdomen, which causes obstruction. And eventually when surgery is done, most of the time, unfortunately, you do surgery without knowing the diagnosis. And then the diagnosis comes out as a bucket lymphoma, which is also a form of non-Hodgkin lymphoma. So extra lymphatic involvement and presentation is also possible. Also, you can get a proliferation of these malignant lymphoid cells until to the extent that they replace and fill the bone marrow, leading to decreased production of the other normal cells, especially red blood cells and HP. So you'll get unexplained anemia and generalized body weakness, or thrombocytopenia. I mean, decreased production of platelets leads to decreased platelets in the circulation, and also increased cases or episodes of bleeding or easy bruising. And then there's usually something we refer to as B symptoms or constitutional symptoms that you can get: fevers, night sweats, weight loss, pruritus, all referred to as B symptoms, which are common in non-Hodgkin lymphomas. So the patients or people presenting with non-Hodgkin lymphoma can have all of these or some of them, or even one of them. So it's important to have an understanding, at least, of how some of the common and rarer presentations of non-Hodgkin lymphomas. I mean, I put this for the general population, some of the warning signs for lymphoma. I mean, fever, swellings in the neck region that have persisted for more than a week or 2 weeks, lumps in the groin, armpits, neck, excessive sweating at night, night sweats, unexpected, unexplained weight loss, loss of appetite, feeling of weakness, breathlessness, or difficulty in breathing, itchiness. These are some of the common signs for a general population. The diagnostic process usually starts with, just like all the other diseases, history, a good history, and or listening to the patients or the clients, and a physical examination. And this is basically to pick the symptoms and the signs that you've already stated. And is the next phase, since the next phase will be involving likely imaging and the laboratory, I must mention that it is very important for whoever has listened to the patient, that is taken history, and whoever has taken the physical examination, to ensure that you document this, a summary of these features, to the next person who will be reviewing this patient sample in the laboratory or in the radiology department. Because remember this, the number 2 and number 3 are done outside where the patient is. That it will be in the laboratory, histology laboratory or hematology laboratory or the radiology department. And since those people will not have the advantage of clerking or taking history and physical examination, there is usually a use of a requisition, a lab requisition form in areas that there is no LIS or laboratory information system or electronic hospital record system. So you always remember, and I will not I will not feel tired of emphasizing the need of including pertinent clinical history symptoms and signs in your requisition forms, because it will help the people who will be evaluating the samples when the patients are not around there. So the next would be taking a blood sample, and of course would be to check the levels of the main parameters, your HB or hemoglobin levels, red blood cells, white blood cells, and platelets. And of course, in cases that are abnormal white blood cells, you can check. You do a peripheral blood film and examine. Usually, a hematopathologist or a hematologist will examine this under the microscope for features that would point towards a lymphoma or a leukemia. SLL, for example, can have lymphoid involvement and at the same time a circulatory involvement. So a diagnosis using a peripheral blood film can actually surface. The next one is in case you don't have superficial nodes or masses, you can do imaging to check for the internal areas like the chest or the abdomen, to check for any masses there and to evaluate. Sometimes even to use the use of image guided biopsy to take there. The next one, and the most important in the diagnosis or in getting a diagnosis of an non-Hodgkin lymphoma, is the biopsy, which more often than not or commonly is the lymph node, because you tend to have lymph node enlargement in the different areas. So if it is generalized lymphadenopathy, it's good to take from either the neck region or the axilla and try as much as possible to avoid the inguinal, unless there is no other like choice. So basically, once a lymph node is removed, it is usually put in a preservative that is we commonly use 10% neutral buffered formalin that most of the laboratories that process tissues prepare. So they should be able to, the clinical or the surgical team should be able to get them from the laboratories, because it is important once this lymph node is removed from the body, you remember it no longer has blood, it's not circulating, it is not warm, it becomes cold, and it can easily autolyse or you get even bacterial contamination, cells die. So it is important immediately, it should not exceed 1 hour. This tissue is put in formalin. If it is very big, if it is more than 1 centimeter, sometimes good to do a bisection or even half bisection of this and put it in a container with adequate amount of 10% neutral buffered formalin. From there, it is usually sent to the lab where they do processing, which is a long, elaborate process in the laboratory, and eventually you get slides that are examined under the microscope by a pathologist, or basically histopathologist, to look for appearances of the lymphocytes, these lymphoid cells, and to make a diagnosis and also to do a classification. So this is the first picture is how a normal lymph node would look like. And usually a normal lymph node would have an afferent areas at the outside and efferent. And then you tend to have a cortex, a medulla, and the cortex usually has multiple follicles. The round pale areas you're seeing are the germinal centers of lymphoid follicles, which usually contain mostly B cells, B lymphocytes. And of importance is to note that these follicles are of different sizes and distributed more towards the cortex, towards the outer areas. And the lymph node, a good lymph node would have a capsule. So it's usually encapsulated. So that is, so when you go high power, you over magnify this, you tend to see lymphocytes, and the lymphocytes are these small dots, and you can actually note that they are uniform. They're quite uniform dots with interspersed larger cells like this, which is a macrophage. You expect them in the lymph node, especially in the medullary areas of the lymph node, and also some dendritic cells that tend to do macrophage activities within the cell. So this is a very nice, normal, uniform appearance of the cells. So pathologists, in making the diagnosis, they look for patterns that deviate from this initial two figures. So number one, you can see this is an example, one of the examples of lymphomas, which is a diffuse large B-cell lymphoma. You look at this and look at this, you realize these are very large cells. That's why the largeness comes in. It's not a dot. You see multiple nucleolus. Some of them have even two nucleus. The pink dot eosinophilic thing at the center is a nucleolus, and sometimes you can see a cell that is actively dividing. We call it a mitosis, and these are mitotic activities. So this is an example of once we say this is diffuse large B-cell lymphomas, and we can even further characterize diffuse large B-cell lymphomas for purposes of prognosis and treatment. A bucket lymphoma is one of these aggressive lymphomas that would, if it is a lymph node, you will see the loss of this architecture and replaced by what we classically refer to as a starry sky appearance. Starry meaning if you look at it from a distance, if you look at the sky at night, you tend to see stars and blue sky or dark sky. So the dark background are your malignant lymphocytes, and while the stars usually represent your macrophages that tend to be engulfing or ingesting the dead cells. Usually malignant cells, when they rapidly multiply, they tend to outgrow their blood supply, and some of them die, and macrophages come in to eat to ingest some of these things, and you get this starry sky appearance for bucket lymphoma. Of course, SLL, CLL usually is a low grade. You tend to get uniform monotonous population of small cells. Follicular lymphoma, I mentioned about these follicles, the pale areas. So in addition, as opposed to the normal one, that you'll get follicles that are of equal sizes or of different sizes. These ones tend to have follicles that are almost similar, very large and almost similar, and distributed in the cortex and the medulla. That is from outside to the inside of the cell. We call it follicular lymphoma, and we further characterize that. I will not go into the details. T-cell lymphomas as well, they tend to be more aggressive, especially in the mediastinum region, and also lymphoblastic. So this is basically how a diagnosis of lymphoma is made in the laboratory by examination of a tissue or a biopsy that is sent to the lab. I must add a well-preserved tissue or a lymph node. And usually this examination requires very well-filled laboratory requisition form. It should never be histology for tissue for histology, or tissue for histopathologic examination, HPE, or tissue for histology. At least try as much as possible to be comprehensive in that region. Additional testing that sometimes we do based on the need is what we call immunohistochemistry. And by that, by definition, it's basically which is an antigen-antibody immunologic is tissue, while chemistry is a reaction. So we basically use antibodies and immunohistochemistry helps us to identify and clarify the cell of origin, especially in tumors that are not very clear, and also to classify tumors or malignant neoplasms into the different subsections for better treatment. And also sometimes we do antibodies or immunohistochemistry to help in targeting or in tailoring treatment as per individual. Sometimes we do also molecular studies. As I mentioned, most of these lymphomas are related, have a genetic abnormality. So to identify the driver mutation and also possible targets for treatment, whether it's in the proto-oncogene gene category or a tumor suppressor gene category. So common markers or immunohistochemistry markers that we do to further clarify or classify lymphomas are these ones which are listed. I'm not going to the details. There are those for B cells, other for T cells, other to check whether the cells that we see in a slide are immature or not, and also specific for the like mantle cell lymphoma, for example. You will do a CD20 to confirm whether it's a B cell lymphoma. You do a CD5, you do a cyclin D1. If it's positive for cyclin D1, it falls in. If it is negative, then you think about 23, 4. So we tend to play this with these markers in a panel fashion. And of course, Hodgkin's have different markers. For Hodgkin's lymphoma, we tend to use CD30 and 15 because Reed-Sternberg cells tend to be positive for this particular two, and plasma cells are CD138 or 38. Ki67 is a proliferative. We tend to see at any given point in time what number of cells are actively proliferating. So we tend to use it to grade our lymphomas. So these are the common panels of antibodies that are stocked in our immunohistochemistry department for especially typing and doing lymphomas, and it's important for the diagnosis. This is an example of how immunohistochemistry is important. You get a young person presenting with a jaw mass or a swelling around this region that is rapidly growing. A tissue biopsy was taken from here, put in 10% formalin, sent to the lab, preserved. Pathologist got the slide, looked at it, did a starry sky appearance, as I showed, and then there was just need to confirm by doing immunohistochemistry CD20 to confirm that it is a B-cell lymphoma, and also Ki67 to see that it is highly proliferating, almost more than 90, almost 100% proliferation of this. So this is how we tend to make the diagnosis and do the characterization. CD20, as I mentioned in the treatment side, is that it helps these other drugs that tend to target CD20. So a tumor that is CD20 positive can be targeted with a monoclonal antibody. As part of destroying the cancer cells. So in terms of treatment, so that I will let the other presenter continue, is that we have a general management of these cases, and the general management are largely supportive. Supportive is to relieve the symptoms, or to relieve symptomatology. We mentioned one of the symptoms would be generalized body weakness or anemia, or easy bleeding or bruising because of thrombocytopenia. So usually they tend to have a transfusion, either of all blood or blood products specific. There's an element of fever and the other B symptoms. And also once treatment is initiated, T cells are usually quite fragile, and they tend to die a lot in a very quick manner, and you can get some byproducts of the dead cells in the circulation and can overwhelm the kidneys, something we refer to as tumor lysis syndrome. So this is usually managed at the start, or at the beginning of treatment, so that you also protect the other organs from the side effects of the treatment, the indirect side effect of the treatment. The definitive treatment is likely to destroy the cancer cells, or to basically destroy completely and stop production of other abnormal cancer cells. So destroying usually requires either chemotherapy, and there are different regimens. I'll not go into the treatment regimen, but I know for most non-Hodgkin lymphomas, especially the aggressive ones, they use usually regimens that are given in cycles, weekly cycles or 2 weekly cycles. You can use monoclonal antibodies, like the ones of antibodies against CD20, which are present in some of these malignant cells, like rituximab, for example, that I already mentioned. Which is a form of immunotherapy, and radiotherapy, especially for lesions that are compressing the spine or causing superior vena cava syndrome, to tend to shrink because radiation tends to kill or to shrink, to kill the tumor cells and make them relieve the symptoms. Of course, the eventual treatment is usually bone marrow transplant or like a stem cell transplant, then to eliminate all the cells, especially the defective ones that gave rise to cancer, and to replace with normal ones. This kind of treatment tends also to kill rapidly proliferating cells in the body, especially the ones that tend to have a turnover, like your skin cells, your hair cells, the cells lining the epitheliums of the gastrointestinal system. So some of the side effects of this, especially chemotherapy, would be related to hair loss because of destruction of those follicular cells there, or diarrhea and vomiting because of the lining of the gastrointestinal system, and the other would be maybe skin changes. But I will probably leave that to the next presenter. We will talk more about those ones. So that should be the end of my presentation. Thank you. Thanks. I'll hand over to the coordinator.
Thank you very much, Dr. Kibet. That is very educative and very expansive. And it makes us understand these lymphomas more and more. You know, sometimes we just say it's lymphoma. We don't know whether it's Hodgkin's, and we keep wondering why people are to be sent for IHC and the rest. But at least that one sheds very good light. And thank you very much. I know questions will come up in the chat box, and we are grateful that this kind of information is coming to us at such a time. Thank you, Daktari. And at this moment, I don't know whether Humphrey Elisha has joined. It's a time I would like to welcome Humphrey Elisha to come, who is a survivor. Elisha has been treated for buckets for lymphoma. I think it's either Hodgkin's or non-Hodgkin's, but he's a lymphoma survivor. And we are grateful to have him with us today. Maybe he can tell us a bit of his journey. Humphrey, it's your time to join if you are there already.
Okay, good afternoon.
Good afternoon and welcome.
Oh, thank you. I had some technical issues, so may you forgive me.
No, it's okay.
My name is Humphrey Elisha Juang. I'm from Kisumu. I'm a warrior and a lymphoma Hodgkin survivor. It was not an easy journey. It was difficult here and there because there are some obstacles here and there, like apartheid, stigmatization after the treatment. Stigmatization came because changing skin color after the treatment. The skin color changed from its original color to blackish, even changing nails color, the hair loss. Yeah, but it was not an easy journey, even though the doctors I had worked tirelessly here and there to help me. What I can just say is that when you are diagnosed with lymphoma Hodgkin's or any other diseases, is not end of everything. It's not a death sentence, let me say like that, because I survived, and there are so many people who survived without tear. And my mentor was my hometown, my home county governor, because he was diagnosed with the disease. His was leukemia so many years ago when I was still in primary, but he survived. So I keep that faith and saying to myself, if my hometown governor survived, what about me? I can also survive. So I keep on moving and following the doctor's directions and medication. So at first I was in Chandaria when I was given chemotherapy, and after that I was given a break of a week. Then after a week, it has a weekly cycle. Then after some weeks, I could report back and again, and I ended up in Chandaria for clinical review, So right now, I usually go back after 1 year. So I'm proud to be alive, and I want to thank my doctors. Dr. Kibet was one of them who helped me in this journey. Indeed, it was a difficult journey, and Ampath organization for helping me a lot because it was too expensive traveling from Kisumu to referral. So they helped me financially, and they were giving me advices here and there, the social workers. Only that I can just say, I'm just proud of them. Thank you.
Wow, thank you very much, Humphrey. And Humphrey is a living testimony to what can happen, especially when a diagnosis is made. I think I remember seeing Humphrey when he was referred from Kisumu, and when we were just supposed to start from zero. And I just want to thank the entire team who saw him through this journey. I think by then he was in primary school, and by now I think Humphrey is in college. And just keeping the appointments, keep guiding the others, because you are now a very good source of encouragement, especially to those who are newly diagnosed. And you can be a very good source of navigation to those of us who don't know the direction to take. And we are also proud that some people can come and tell the story. Telling the story is something which is really and really encouraging. For those who hear the stories, they really know that actually cancer is not a death sentence, as many people think about it. It's not easy when a diagnosis is made for a very young person. Psychologically, you have many things traumatizing you. Here you are, you don't even have a way of getting treatment. And thanks for such programs, the lymphoma program at the Moi Teaching and Referral Hospital and at the Ampath Oncology program. It has been helpful to many other people. And through this program, some have revolved back to life, especially when they had exhausted everything that they had on treatment. Through some grants, they were given some seed money to start off their business again. And this is good because when somebody has gone through cancer, all the resources are depleted. Thank you, Humphrey, and we are happy to have you here any other time. And maybe if there will be questions, you'll address them. And at this moment, I just want to welcome Francis. It's either Bomer or Boma. And Francis is a Master of Science as a MSN Oncology, a nurse practitioner at the Hemato-Oncology Unit at the Kenyatta National Hospital. Humphrey is very aggressive in the work of these patients, and they are the people, the pillars that make us happy that some people are there to make oncology stand. You know, even if you prescribe, even if you take biopsies, you do the diagnosis, and unless you have nursing, a strong nursing team behind the care, behind supportive, behind palliative, behind chemotherapy, you cannot make it. So Francis, you are welcome. Take us through the nursing perspective of non-Hodgkin's lymphoma. Karibu.
Thank you. Just a minute. I don't know if you can see my screen. Hello?
Not yet. I can't. Or maybe you can click something which looks like a human head at the corner. Then, yeah, now we can see. Yeah, it's possible. Just go to slideshow, then it will move on well.
Okay. Okay, thank you so much. Thank you for the brief introduction. My name is Francis Bomel. As you've mentioned, I work here at Kenyatta National Hospital as an oncology nurse. I'm a graduate from the University of Nairobi with Masters of Science in Nursing Oncology, Oncology Nursing. So I'm going to pick it from where the debate left. And basically, Basically, I'm going to talk about the data, the burden. I'm going to briefly maybe mention maybe stress one or few things on the signs and symptoms. And then the nursing management. Management as per the nursing perspective. And then there's the issue of prognosis, and then post-discharge or caregiver's advice. So in terms of burden, non-Hodgkin's lymphoma is one of the most commonest blood disorder, as you can see globally. According to Globocan, the statistics show that there was an estimate of 544,000 new cases of non-Hodgkin's lymphoma in the year 2020, and out of which about more than half of them died because of the disease. That's around 260,000 people died. It is one of the most common, as you can see, the sixth most common cancer, especially in the US, which represents about 4% of all the new cases in the US each year, and 3% of all the cancer deaths in the US. So you can see, even with the stable economies, the disease is still killing people, because 3% is not a small number when you talk about a country like US. In other jurisdictions in the US, still about 80,000 new cases diagnosed annually, and in all groups there were about 20,000 deaths. So in Eastern Asia, the disease is more common, which I will show you later and you see the diagram presentation, whereby about a quarter, that is 24.9% of all cases globally are found in the Eastern Asia. And it's followed by the Northern America with around 15.1%, then South Central Asia is around 9.7%. These are as per the Globocan statistics. In Kenya, the malignant lymphomas accounted for around 12% of all the surgical pathology specimens processed. And patients who were diagnosed ranged from the 4 years to 97 years. And the median age was 35 years. That is as per the CDC statistics. The prevalent types of cancers, especially in where I work, KNH, leukemia accounts to around 30%, retinoblastoma 23.3%, Wilms tumor 16.9%, and then you can see the lymphomas around 16%. Then malignant neoplasms, connective tissues, and those others around 9.1%, and neuroblastoma 4.1%. This is as per the statistics of the KNH in the year 2020. So in terms of distribution globally, you can see in this diagram, the non-Hodgkin's lymphoma is around the 11th in terms of ranking, with the cases of around 544,352. And in terms of the deaths in both sexes, it's still one of the major killer, contributing to high mortality of around 259,703 cases. These are big numbers. In terms of incidence, you can see globally, Africa, we are at 9.3%, and you can see Asia is around 44.3%, Europe 22.6%, and North America 15.1%. And in terms of incidences, Asia is still leading at around 51.4%, and Africa, you can see we are at 11.9%. In terms of the five-year prevalence rates, Africa, we are at 7.2%, and you can see Asia is still leading at around 41.4%. So these statistics shows the kind of impact that the disease has globally. You can see, you may wonder why Africa we have less in terms of numbers, and yet we still have quite a number of patients we are admitting. One, I would attribute to one, you can all agree with me that we don't have enough data compared to those other countries like Western or even Asia. So that could be one of the problems that I could attribute to that. The problem could be bigger than what we can see. So in terms of management and the nursing perspective, so management interventions of lymphoma are normally, when we talk about nursing, we are based on cognitive behavioral theory, which in this case, we want to help the patient to understand the nature of the symptoms. We want them to believe in the ability to control the symptoms and teaching the patients on problem-solving skills. Humphrey can bear witness that without the support, most likely he would have given up along the way. And basically, because this is what could have been done, that is why we have a warrior like Humphrey talking to us today. So basically, as nurses and other healthcare workers, we want to allow patients to discuss their own feelings. We want to encourage them to accept expressions and express their concerns, anger, and grief. And also we refer to appropriate community resources. And I'm happy that we have such institutions like the National Cancer Institute, which play a very critical role in terms of mobilizing community resources. Assessments such as continual monitoring of vital signs, neurological checks, ins and input and outputs, range of motion exercises are very important to ensure that the patient's well-being. Because in most cases, these patients come to us when they are very sick, though in most cases they are dependent. They may not do even activities of daily living. So that is very critical in terms of planning the care of this patient. And then I'm going to emphasize on effective patient education, because patients normally when they come, when they are admitted, when they are diagnosed, they have a lot of questions. And in most cases, they go to a large extent in looking for information. Some of them go to Google, some of them talk to other relatives. They look for information from any source, because it is quite distressing once we diagnose with the disease. And of course, the palliative care. Palliative care in this case is what we do to make this patient comfortable. We want to relieve the symptoms, at least let the patient have a good quality of life, even as they continue with their care. Some of the priorities that we want to emphasize is one, comprehensive assessment. Dr. Kibet mentioned about how we diagnose, and we can only arrive at that diagnosis through comprehensive assessment. This is by thorough assessment of the patient identity and the physical, emotional, and psychological needs. Also, this assessment should include review of patient's medical history, physical exam, and laboratory tests, which are quite a number. Then there is the issue of symptom management, because some of these symptoms are quite distressing to the patients. It's always good that even as we plan the care, we want to relieve those symptoms so that the patient can continue in care. So non-Hodgkin's lymphoma may cause a range of symptoms. Mainly, we have fatigue, we have pain, nausea, and vomiting. Nausea and vomiting sometimes may occur because of the disease process, and at times because of the management or the therapy that the patient is on. So assessment, other assessments such as continual monitoring of vital signs is key, and also neurological checks in and outs, and also the range of motion. They are very important to ensure the patient's well-being. So vital signs is also very important because you realize that the disease affects the very key components of the blood, the lymphocytes, which are play a very critical role in fighting infections. So the first thing that you want to monitor is maybe the patient should be free from fevers, because the most common signs of infection. And then, of course, the neurological symptoms, because you realize the disease sometimes can affect it can even go to the brain, and so the patient may present with neurological symptoms. So you want to check to see if there are any elements of confusion and all those other things. So these are safety issues. The reason why you are doing that, because you want to maintain safety even as you continue with the care of these patients. So as nurses, you should work with the patients to manage these symptoms through medication, through other techniques such as relaxation, if you want to relieve pain, and other supportive measures. This will happen with effective communication and collaboration between the health provider, the nurses, and the patients. Another key thing that is priority in management of lymphoma is monitoring of the complications, and complications will arise because of the disease process and the treatment. So some of the complications that we have the hemorrhage because of the low platelets. So these are the things that we, as a health provider, as a nurse, we want to ensure that the patient is monitored for that, for any signs of bleeding, and so that can be controlled adequately. And also, treatment of course come with a lot of side effects, which are sometimes they are toxic. And it's our responsibility to ensure that we monitor for those complications. So patients also with lymphoma, non-Hodgkin's lymphoma, are at risk of developing complications, and as I've mentioned, we have infections and bleeding. So these patients should be monitored closely for those signs of complications. In terms of complications, there are those which are immediate and there are those which are delayed. When you talk about immediate complications, these are complications that occur maybe anytime between the patient is diagnosed or started on therapy and maybe 10 years. In most therapies, the infection occurs during that period because of neutropenia. Although use of other factors, growth-relating factors such as the glucosamine or nicotin play a very key role. It's always good to be on watch out for those signs of infection, which may pose a big problem, which complicate the care of this patient. You have gastrointestinal effects, adverse effects, which mainly occur due to chemotherapy as a side effect. And some of these can be managed adequately by administering adequate medication for these patients, that is antiepileptics and other adjuvants, so that the patients can cope with those symptoms, relieve. And also key is that also the issue of adequate hydration is also important to ensure that the patients don't develop other renal complications. And also we have other complications such as cardiomyopathies and arrhythmias, which occur secondary to some therapies such as anthracyclines. So it's always good to watch out if the patient is on such medication. Those are some of the risks that this patient can develop. Also, there are those complications that occur because of the drugs and radiation therapy. These are late complications because if a patient is on radiotherapy, the first 10 years of treatment, there is risk of myelodysplasia and acute leukemia due to bone marrow damage, due to that radiation effect from certain, and also from certain chemotherapeutic agents. After 10 years, normally some of the complications that occur are mainly if the patient had received maybe a radiation, maybe the chest. These are the patients who can come with other complications relating to that. And then another priority that is put in place is the issue of education and support. It is very key. It should be provided to the patient and the family with adequate education and support through the treatment process. Without that, some of these patients will just drop out of the management, and definitely the outcome will not be good. So normally what happens in such cases, immediately upon diagnosis, the patient and the family are always put on what we call family conference, whereby they are given information about the diagnosis, the management plan, and also the patient is free to ask questions relating to their condition, and they will be answered adequately. Because without that, some of these patients come to us with a lot of expectation, and whenever the expectations don't materialize, they end up blaming the system or the management that this patient was put on. So allowing patients to discuss their own feelings, encourage them and accept expressions of concern, anger, and grief, also refer appropriate community resources. So this is very key, because as I say, the disease causes a lot of distress, not only with the patient, and even but also with the family. In terms of, because the family really wish to do anything they can to offer to this patient. So it's always good to allow them to express their feeling and concerns and address them as they continue. And also anger and grief in case the outcome is contrary to what they were expecting. So this information includes the disease. Normally during family conference, you're talking about the disease, the diagnosis, the treatment options, the potential side effects of the management of the drugs that the patient will be put on. Because if a patient, Humphrey talked about some of the complications or side effects of the therapy that he went through, the issue of loss of hair, the issue of skin color, change in skin color, and all those other things which can make the patient develop low self-esteem and feel stigmatized. So the issue of family conference and education and support will help in alleviating those challenges. And then emotional support is also key in helping these patients cope with the diagnosis, treatment. So in terms of emotion, there are many stakeholders that would come in. We also have the family, of course, it is very key. And also we have the team, the multidisciplinary team, which is managing this patient, to ensure that this patient gets adequate emotional support during the journey of management. So some of the key things that you want to discuss during that family conference, just in snapshot, you have the signs and symptoms, you have the diagnostic methods, how the disease is staged, the potential outcomes, the treatment options, fertility issues. Fertility issues is also key, because we saw the average age, the median age of 35 is these are the people who are at reproductive age, and they have, of course, there are concerns on fertility issues which should be addressed, because you don't want a situation whereby you start the patient on chemo because you've not discussed the issue of fertility or issue of conception. Within the second cycle, the patient comes to you already pregnant, for that matter, now complicating the whole management plan. Also, there is the immunosuppressivity due to chemo, which is very key, so that you want to teach this patient on the infection prevention and also signs of tumor lysis syndrome, which is quite can be an oncology emergency, especially for patients who are on chemo. And then how to deal with pain due to the tumor, especially if the tumor is pressing on the nerves. So basically, those are the things that you need to educate your patient on. And then another very key important issue is the issue of nutrition and hydration. This one I cannot overemphasize, because without nutrition, even the management may not, the patient may not benefit from management. So patients with non-Hodgkin's lymphoma may experience loss of appetite, weight loss, and dehydration. So we want to address this by providing this patient adequate nutrition and adequate hydration. So this can act as a palliative in nature and also as a management strategy for that. So nurses and other health care workers should work with the patient to ensure that they are receiving adequate nutrition and hydration through the dietary counseling on hydration. So this is when we need nutritionists to come on board so that they can take over the issue of planning the diet of these patients. Then another very key aspect of management is the coordination of care. And normally the care is normally handled by the multidisciplinary team. And when you talk about multidisciplinary team, it's bringing on board all people who take part in management and direct management of these patients. So as nurses and as doctors and as other health workers, we need to work closely with other healthcare team to ensure that the patients is well coordinated, the care is well coordinated, and all aspects of their treatment are addressed. Some of the multidisciplinary team that we want to put in that are very key in management of this disease, we have the hematologists, we have the nursing team, we have the medical radiation oncologists, pharmacists, pharmacists, dietitians, social workers, support groups, physiotherapists, occupational therapists, psychologists, spiritual team, and other clinicians that play a very key role in managing these patients. And then we have the prognosis. So after doing all this, what are the prognosis? The patient would want to know what are the prognosis in terms of the non-Hodgkin's lymphoma. So the 5-year survival range between 26% to 75%, depending on the number of unfavorable factors. Of course, according to International Prognosis Index, it considers 5 risk factors. One is if the patient is above 60 years, of course, that one is unfavorable. And then there is the poor performance status using the ECOG scale. And then the elevated lactate dehydrogenase LDH level, especially upon doing the histoimmunochemistry. And then we have the more than one extranodal site, the lymph nodes, and then the stage of the disease, whether stage 3 and stage 4 normally have poor prognosis. So patients with indolent follicular lymphoma have a better 5-year prognosis ranging from 52.5% to 6%. That is high to low. And the median survival patients with indolent follicular lymphoma is around 8 to 12 years. So in general, patients with peripheral T-cell natural killer cells, T-cell lymphomas typically have worse prognosis than those with B-cell or non-Hodgkin's lymphoma. That is my presentation, and those are my references. Thank you so much.
Wow, that was wonderful. Thank you very much for that elaborate presentation, building into what Dr. Kibet also has presented and the experiences has presented by Humphrey. And that is exactly what happens when someone gets cancer. It may be easy to talk about cancer, but it's really hard to walk through cancer unless you have a multidisciplinary team whereby you have people who are taking care of your psychosocial issues, people taking care of your insurance, others taking care of your diet, others taking care of maybe other physical and economical support, and also for those who are young, because even we get quite a high rate of youngsters getting the lymphomas, both Hodgkin's and non-Hodgkin's. You need also people, your peers, to walk with you through. There are many questions about the CPD, but those ones, someone is addressing them. Now I have a comment here. I don't know whether it's a question or a comment, but the conclusion will lead us from Martin Afuko. I applaud the presentation, and it is obvious without looking at health from a social model for non-communicable but lifelong diseases with comprehensive health insurance. Our success as a nation is still marriage for most of our rural populations. Management of long-term illnesses, that is ADL, performance, and maintaining occupational engagements once a diagnosis is made. Patient education should cover all family members and employers, especially non-formal employers who are quick to deny income to employees once diagnosed. Once a diagnosis is made and regular visits to hospitals start, overall, it becomes difficult for patients to have the will to carry on with life shortcomings of conditions notwithstanding. I agree with you. That is actually the reality. Some people get sacked because they are taking long sick offs, because they're spending a lot of time in the hospital. So how do we navigate through this and help one another. Thank you for that comment, Martin. From Irene Olo, in Kenya currently, do we facilitate home-based care for patients who need it? I don't know whether, Bomer, you have an answer for this. Do we facilitate this? Because I think you are dealing with care.
Yes. Thank you for that question. Thank you for the question. Yeah, we do facilitate home-based care, but we do that by one, educating the family and explaining to them the management of care, because sometimes this patient comes when the patient may not benefit from the hospital. One, the patient may not start chemo, and the patient, instead of keeping the patient in the hospital, exhausting the cover, the NHIF cover, or those other things, we normally advise our patients to consider an option of home-based care, and some of them have taken it positively. Of course, there are challenges with that, and I think in other jurisdictions whereby the cover should include the home-based care, I mean, the NHIF should also include that as a package, so that this patient can enjoy the care at the comfort of his or her home, of course, with help of professionals. Thank you.
Thank you very much. Thank you very much for that response. Most of the issues expressed here are maybe just appreciating the presenter's excellent presentation. Kudos to Dr. Kibet. All questions about CPD are going to be addressed. Then wonderful presentation from Bronson Traiter. I think I can't see any other question. I don't know whether there is any comment from Dr. Kibor. Dr. Kibet Kibor, any comment?
Not as such, but just the need to advocate for more availability of diagnostics to reduce the times that people who are suspected to have like these cancers like non-Hodgkin lymphomas take to get the diagnosis. Thanks.
Thank you very much, Dr. I think we really need to see how we can advocate for maybe diagnostic, and then after diagnostics, what next? Because maybe a screening can be done. Look into even other cancers. You do a screening, you get somebody with a mass, you assist that person through maybe a biopsy, then Dr. Kibet gives us the results. Then what next with the results? So this is the direction. If we want to decrease the cancer burden, this is the direction we need to look into. An end-to-end care, and whereby there is diagnosis, there is management, there is survivorship. Because when we only diagnose, we say, okay, we have this number of lymphomas, then what next? What do you do with the lymphomas? So it's actually an area where we really need to advocate so that the policymakers can get us funding to help people through. Because when you look at the PAVA index of an ordinary Kenyan, even going for a diagnosis has become a challenge. I remember one time we did some screening somewhere, then biopsies were removed and patients were given to take to the labs. Then the following year, when we went for the same exercise in that place, we found the same patients whom we screened, some of them had not even been done. The biopsies had not been processed. Then when we asked for the client that we remove the biopsy, again, he said, now, am I going to have two of them? Because the other one I'm still keeping in the room. So it is that pathetic. Thank you very much, Dr. Kibet. Thank you, Humphrey Elisha. Thank you, Bomer, for these presentations. And on behalf of all those who have joined, I just want to say thank you. And to those who have joined, this is a huge number. It means we really need to have this platform to put in more knowledge, more information, so that a lot of information can go around. And I would like just to take this opportunity to hand over back to Kenko so that they can take over and give us closing remark. Otherwise, I'm Pamela Were. I was moderating the session, and I'm glad that I was in this panel. Thank you.
Thank you so much, Pamela. Thank you for taking up this chance to participate as a moderator. I would also love to thank everyone who has joined us for this particular webinar. My special thanks to Dr. Kibet for the comprehensive presentation, Mr. Bomer for the nursing bit that was quite informing, and for Elisha for the amazing story on non-Hodgkin's lymphoma. And also, I would also love to thank the KNH team, the ICI team, and recognize and acknowledge our main sponsors, Janssen. For more of this, I think we will also gather here next week for a webinar on bladder cancer. Thank you very much. See you next time.
See you.
Also, before you log off, I would like to post the nursing CPD code for today. So kindly nurses, before you leave, please note that we are posting the nursing code CPD for today's session on the screen momentarily. Thank you once again for joining. Nursing Council CPD is being posted on the screen right now. So if you're a member of that body, kindly be keen to get the nursing code for today's session. It is posted on the screen. It is 5WLQ. That is 5WLQ. Kindly check the screen for nursing code for today's nursing code CPD.
Thank you for that.
Wonderful.